this chapter we are going to see about the lymphatic system. Okay, we are going to discuss about the lymphatic system. So lymphatic system, the major disorder we are going to discuss is about the lymphedema. So can I tell what is the most common cause of lymphedema all over the world? Worldwide, the most common cause is filariasis. So in Indian cases are so much in number, increases the world census. Okay, Indian cases of filariasis increases the world level census also. So what is the most common cause of upper limb lymphedema? Upper limb lymphedema now has overtaken filariasis, and now it is post-mastectomy. Axillary lymph node dissection causes post-mastectomy upper limb lymphedema. Okay, so the lymphedema can be classified into classification of lymphedema is into very two important topics. They are primary and secondary lymphedema. Primary lymphedema can also be said as congenital lymphedemas. Congenital type of primary lymphedemas are secondary is due to some causes. Like what are the causes? So the most common cause already we discussed, filariasis. So filarial causes, some fungus, fungal tinea pedis can cause filariasis, and following radiotherapy, following malignancy, following surgery like axillary dissection, following radiotherapy, following malignancy, following surgery, or following some trauma, or following superficial thrombophlebitis. So following a superficial thrombophlebitis, following DVT, all these are some causes of secondary, including exposure to silica particles. Silica exposure, all these are secondary causes in billion now. So in the secondary causes, please don't forget the most common causes filariasis. So other causes include fungal, radiotherapy, malignancy, surgical treatment like MRM, modified radical mastectomy, trauma, superficial thrombophlebitis, deep vein thrombosis, silica, all those things can cause secondary lymphedema. So the congenital or primary lymphedema can be divided into further three types, which happens within 1 year, which happens in 1 to 35 year, and which happens above 35 year. What are they? So this is less than 1 year known as Milroy's disease. 1 to 35 year is known as Meeks disease. Above 35 year is known as Targa. So I'm going to discuss about those three now. It is there in billion now. So congenital lymphedema or primary lymphedema, three types. Primary lymphedema, in which there is no specific cause. You don't know the cause. It can happen in less than 1 year children as congenital. It is known as congenital when it happens less than 1 year. And usually these babies will have both lower limb involved. Up to thigh. Bilateral up to thigh is involved. It is involving bilateral up to thigh. This disease is known as Milroy's disease. That is a family. Milroy's family, in which the family people, all of them are having this disease. I will show you the Milroy's, the original Milroy, from whom the entire family had the disease of Milroy. Like bilateral full limb lymphedema less than 1 year. So then comes 1 to 35 years. That is known as lymphedema precox, also known as Meeks disease. Another name is Meeks disease. It is more common in females, and it is most commonly unilateral, not bilateral. It is commonly unilateral. In this condition, it will involve only one limb below knee like this. Other limb is normal. It is unilateral, involving only one leg. That is also below knee only. That will also involve only below the knee. That is Meeks disease. So Milroy's disease, both leg bilateral. Meeks disease, one leg below the knee. Okay, one leg below the knee. And lymphedema targa is above 35 years. Is known as lymphedema targa. The disease is known as lymphedema targa above 35 years. Okay, so now let us see what are the clinical features in a lymphedema. Okay, so the lymphedema classical features. It's not the important differential diagnosis of lymphedema. It's not the important differential diagnosis of lymphedema. And unlike other causes of lymphedema, this is more confined to foot and ankle. It is more confined to the foot, especially the foot, and especially foot and toes. It is more confined to foot and toes. Therefore, if you see this patient, the leg will be looking like this. Like what is it looking like? It is looking like a buffalo hump. It looks like a buffalo hump. It has a buffalo hump. It has a square foot. There is square foot. The toes look like a square foot, and the dorsum of the foot looks like a buffalo hump. And when we try to pinch the skin cannot be pinchable, known as Stemmer's sign. The skin is not pinchable, known as Stemmer's sign. Okay, so what are the other clinical features? Stemmer's sign, buffalo hump, square foot. What are the other clinical features? In a filarial lymphedema, they will have eczema, severe eczema. They will have severe fungal infection. Fungal infection is present. And when the fungal infection involves skin, it is dermatophytosis. When it involves nail, it is onychomycosis. Onychomycosis, if it is involving the nails. If it involves the skin, it is known as dermatophytosis. Classically, they will have fungal infection. And there will be fissures. Verruca, and wart. That is why it looks like an elephant leg. That is why it is known as elephantiasis. Fissures, verruca, wart, all these make the leg look like an elephant leg. And there may be ulceration is usually unusual. If it is present, you should rule out underlying venous insufficiency also. Underlying venous insufficiency may have this ulceration. Otherwise, usually ulceration is unusual. And these lymphedema patients may get a problem known as lymphangioma. What is the problem of lymphangioma means? Lymphangioma is nothing but dilated dermal lymphatics. The dermal lymphatics are getting dilated and look like a blister. This is known as lymphangioma. Dermal lymphatics looking like a blister is known as lymphangioma. It usually contains clear fluid and does not contain blood. Please remember, it contains clear fluid and does not contain blood. It can get thrombosed. And looks like a nodules, which gives an important differential diagnosis as looking like a malignancy. The nodules look like a malignant deposit. So this lymphangioma can form blisters. That blisters contain clear fluid. Very rarely they can go for thrombosis, and it looks like a nodule. Okay, there are many types of lymphangioma. When it is less than 5 cm size, it is known as lymphangioma circumscriptum. Less than 5 cm is known as lymphangioma circumscriptum. If it is diffuse, it is known as lymphangioma diffusum. The reticulate pattern, sometimes it has a reticulate pattern. So reticulate pattern of lymphangioma is known as lymphedema abigni. Lymphedema abigni is a reticulate pattern present. So reticulate pattern is present known as lymphedema abigni. So please don't forget these three points. Lymphangioma circumscriptum, lymphangoma diffusum, lymphedema abigni are the various features of lymphangioma. And sometimes these lymphangiomas can ooze out known as lymphoria. Also known as chyloria. Lymphoria and chyloria can happen. So they can ooze out. The lymph can ooze out known as lymphoria or chyloria. Sometimes it can also cause diarrhea, protein losing diarrhea. It can produce chylothorax. It can produce chyluria. All these are various other complications from these lymphangioma or lymphectasia rupturing into various cavities. It's rupturing into various cavities, and that is known as chylous reflex. All these happens due to chylous reflex. Okay, please don't forget, these are the points you should not forget in lymphangiomas. So now lymphedema can be graded from alien law, known as Brunner's clinical grading. Brunner's clinical grading system is expected MCQ. Grade 1 in Brunner's is having pitting edema. Usually, if you see, the lymphedema will have the classical feature of stemmer sign, inability to pinch and no pitting edema. If you are having pitting edema present, pitting edema is present and the edema disappears on lying, decreases on lying overnight, is grade 1. Grade 2 is a condition in which there is no pitting, no reduction on lying. There is only one sign, that is stemmer sign positive. This is a classical MCQ. Stemmer sign is positive in which lymphedema means it is grade 2 lymphedema. Grade 3 is a condition in which there is skin changes like fibrosis and papilla. Fibrosis and papilla like an elephant leg has happened here. So these are all irreversible skin changes. The patient has developed fibrosis and papilla. It is irreversible. Please remember, it is irreversible skin changes. Irreversible skin changes are seen known as fibrosis and papilla. So the moment you diagnose a patient with lymphedema, we have to advise them the following conservative treatment. So lymphedema is usually treated by conservative most of the time. So the conservative treatment include pain management. You should give them painkillers. They have severe pain management. And if there is an infection of the lymphedema, there may be lymphangitis may happen. That is treated by antibiotics. Usually the lymphedema going for lymphangitis is caused by streptococcal infections. Streptococcal infections can cause this, so they can need antibiotics. And more important is we should manage the skin fibrosis, papilla, dryness, eczema should be managed. Skin management is the most important thing. We have to put good oily moisturizer should be put on the skin. It should not be allowed to dry. Moisturizers should be applied. It should not be allowed to dry, and you should use antifungal ointment if there is a fungal infection. Antifungal ointment is used. So skin management is the most important in lymphedema, and we have to use multi-layer compression stockings. Same like we used in varicose veins. Here we use multi-layer compression stockings. So multi-layer compression stockings are used here, and in varicose ulcer we used up to 35 millimeters mercury. Here we use it more than 35 millimeters mercury compression. The compression stockings will be more than 35 millimeters mercury. Compression stockings will be there, and the compression will be graduated. It will not be the same everywhere. It should be used in such a way. At the level of ankle, we should give 100% pressure. When you go at knee level, it should be 70% pressure. In the mid-thigh level, it should be 50%, and in groin, it should be 40%. So it should be getting reduced as you go up. The highest pressure is maintained in the ankle level. 100% is maintained at the ankle level. And you should advise these patients to undergo exercises. Vigorous exercises should not be done. Please remember, vigorous exercises are contraindicated. They should do only mild exercises. Like what? What are the mild exercises you advise for a biliary lymphedema patient? Like swimming, they can go for swimming. Or rhythmic exercises, they should do rhythmic exercises. They should not do vigorous exercises. Slow rhythmic exercises are advised. Don't do vigorous exercises. If you do more vigorous exercise, there will be more edema. If you do slow rhythmic exercises, the venous outflow of the lymph will cause reduction of edema. Okay, so exercises, and there are not much drugs available. Drugs are not much available to reduce the biliary lymphedema. Only we give them tablet DEC, diethyl carbamazine, can be given during the acute phases of acute exacerbation time. We can give tablet DEC. Otherwise, drugs are not much helpful. Okay, therefore drugs are not much useful according to Bayesian law in lymphedema. So the surgical options, though we are not commonly using surgical options, you should have an idea about the surgical options. Surgical options in lymphedema can be divided into bypass procedures, and limb reduction procedures. So limb reduction is commonly done procedure. So, but let us have an idea about the bypass. Lymphatic bypass using a omental pedicle. Lymphatic bypass using omental pedicle or skin bridge or ileal mucosa. So these are all various bypass using omental pedicle from the thigh or skin bridge or ileal mucosa. The ileal mucosa is known as Kinmonth operation. Kinmonth. Skin bridge is known as Gillies procedure. So skin bridge bypass is Gillies. Kinmonth is ileal mucosa bypass, and we can also use lymphatico-venular anastomosis. Lymphatico-venular anastomosis, or we can use lymph node to saphenous vein anastomosis. That is also known as Kinmonth. So lymph node to saphenous vein is also known as Kinmonth. Lymphatico-venular or various bypass operations not much successful. All these bypass operations are not much successful. So the successful operations are usually limb reduction, like Charles, Sistrunk, Thompson, and Homans. I'm going to explain about these operations one by one now. So first, let us have an idea about Charles procedure. All of the explained in Bayesian law. I'm not taking anything from except out of Bayesian law. In fact, vascular surgery, if you are going to read, don't read any other book. Even surgical super specialty aspirants or postgraduates, just read Bayesian law. Arterial system, venous system, lymphatic system. Extraordinary Bayesian law. Okay. So if you read Bayesian law, that is enough for artery, vein, and lymphatic system. And I have taken most of the points only from the Bayesian law. Okay. So Charles procedure. What is Charles procedure? This is a lymphadematous leg like this. And this is a normal subcutaneous tissue of that fellow. So in this patient, what we do is we remove the entire skin and subcutaneous tissue up to the muscles, up to the fascia or muscles. We remove it, and we put the split skin graft above. So this is most unsatisfactory operation. Entire skin and subcutaneous tissue removed, and SST is done. What will happen? There will be continuous lymph ooze. The patient will have continuous lymph ooze. Many patients died of sepsis in Charles procedure. So nowadays we are not doing Charles procedure. Then comes cyst trunk operation. In this cyst trunk operation, if you see, this is a lymphadematous tissue, and this is the subcutaneous facial pain and other muscles here. In this, what we do is we cut a wedge like this, wedge of tissue like this. Wedge of tissue is cut. So we cut a wedge and approximate the remaining. So we cut a wedge excision of skin and subcutaneous tissue and reapproximate. So one of the good operation. It is a good operation. Reapproximation. So skin and subcutaneous removed and we reapproximate. So there is no lymph ooze or lymphuria. So this is cyst trunk operation. Thompson. I'm putting P here very big because the interesting point is, if you see, this is a picture in a cut section view. So this is a muscle plane. In this, what I will do is I will remove the tissues from here, all the tissues from here, and I will make this skin flap go and overlap like this. So in which case, after removing the tissues, I will make the skin overlapping like this. So the skin is inside the skin. So the skin is inside the skin. What will happen? There will be P. What is P? Pilonidal sinus will happen. So Thompson operation is a buried dermal flap. Buried dermal flap operation. there is a buried dermal flap which will have pilonidal sinus is a complication. Pilonidal sinus can happen. That is why I put P more big. P for pilonidal sinus is seen in Thompson operation. So these three are not so satisfactory. The satisfactory operation is Homans. Homans is the most satisfactory operation. What we do in this is we raise the skin flap. This is underlying muscles. We raise the skin flap, remove all the tissues from beneath. By a flap, the flap is raised, remove all the subcutaneous tissues and reclose the flap like this. So the major problem in Homans is the skin flap necrosis can happen. Skin flap necrosis is the problem in this operation. But anyhow, this is the most satisfactory operation. Among various operations, this is most satisfactory operation known as Homans operation. Okay, so please remember this is a very interesting Homans operation is most satisfactory operation. So please remember, in case of Charles, what he did, Charles removed everything and put a split skin graft. Sistran removed in a wedge, like a wedge, and closed it. And Thompson did a buried dermal flap, so that is pilonidal sinus. Homans raised the skin flap, removed the tissue, and closed the flap. So that can be skin flap necrosis which can happen. So that's all about the filarial lymphedema. So there are many more problems related to lymphedema. One thing I would like to discuss here is chyluria. So chyluria, the most common cause is filariasis. Most common cause of chyluria is filariasis. Okay, so around 1 to 2% of the filariasis patient get this chyluria in their lifetime. And what is the characteristic feature? The patient will come with a classical feature of passing painless, milky white urine. Milky white urine will be passed. So chyle is coming out in the urine, so it is actually losing the protein. So the patient will land up slowly in hypoproteinemia. If you're not going to intervene, the patient will land up in hypoproteinemia. Sometimes the chyle can block the urinary pathway, and the patient may come to you with a classical clinical picture of renal colicky. Renal colicky can be present. That also is another feature. So chyluria can be caused by filariasis, or ascariasis also can cause it. Malaria. There are many causes. Malaria, TB, and many other causes. Even tumor can cause it. Okay. So the investigation to be done is IV urography should be done. IV urography or lymphangiography should be done, and we have to identify the communication present. So we have to identify the communication present, and surgical treatment is advised if it is not getting cured with a conservative treatment. What conservative treatment usually we do? You usually give low fat, high protein diet, plenty of liquids. We restrict the fat diet and we can give medium chain triglycerides like in any other chylothorax or chylo other places. So like other places we give medium chain triglycerides, restrict the fat, give high protein diet. With that itself the chyluria is resolving, no problem. If it is not resolving, we have to do laparotomy and we have to close the communication. Okay. Another treatments like sclerotherapy is also tried. Sclerosens are also tried, are also attempted but not much benefited. Are also attempted. Okay. So this is about the lymphatic system. Let me show you the images of the various surgeries we do. So please don't forget lymphatic system is a classical lymphedema. You can see it will be more classically involving the forefoot like a buffalo hump and square foot. This is a fellow Milroy's, which is involving bilateral full leg. Okay, Milroy family. And this is lymphangioma circumscriptum in which the lesion is less than 5 cm size. And the lesion is less than 5 cm size, it is known as lymphangioma circumscriptum like this. Okay, if it is involving like a reticulate pattern, like this is known as lymphedema ab igni. It's a reticulate pattern of lymphangioma. Okay, so there are malignancies associated with lymphedema. I want to remember here what are the malignancies which can cause lymphedema. All of you know Kaposi sarcoma and lymphangiosarcoma. Most of you will know that. Like lymphangiosarcoma is Stewart-Levy syndrome, Kaposi sarcoma in HIV patients. Squamous cell cancer, basal cell cancer, malignant melanoma. All of these skin cancers by producing metastatic obstruction of the lymphatics. Okay, by obstructing the lymphatics by some method. Liposarcoma, lymphoma, MFH. All other causes of lymphedema. This is table taken from Bayesian law. So please remember this table. Malignancies associated with lymphedema. So Brenner's getting grade 2 is stemmer sign positive. Grade 2 is stemmer sign positive. Surgical treatment, I'll show you this is system. So this is Charles procedure. You can see the entire skin entire tissue is removed and we have put a skin grafting here. This is Charles. So you can see another Charles. Cyst trunk. Actually, this picture is given a name wrongly in Bailey as Homans. This is actually a cyst trunk. Wedge of tissue is excised. This is cyst trunk. In Bailey now the image is mentioned wrongly as Homan. That is wrong. This is cyst trunk operation. So this is Thompson buried flap. We remove the subcutaneous tissue and you can see the skin is going inside like this. So there will be burial of the skin. Therefore, there will be pilonidal sinus. Thompson P for pilonidal sinus. So this is the Homans operation. We raise the skin flap, remove the filarial lymphatic tissues will be removed out and then we close it back. The problem is this skin flap can go for necrosis. Okay. So chyluria, please don't forget, chyluria is treated by surgical treatment of the dilated lymphatics. Okay. So that completes the vascular surgery in total. So we have discussed arterial system, venous system, and lymphatic system. Be thorough with all these systems. So lymphatic system is a small system, but in Bayesian law they have explained enormously. So whatever is lost in exam, I have discussed here. So if at all you want to read in depth of vascular surgery, please go with Bayesian law. Thank you.